Evening, guys. So if one of you can hear me, can you just unmute and say hi?
Hi.
Good. So it's a minute past 7. Today is not going to be a very long talk. I think we can start. Is it okay, Leonie?
Open this
This
side.
side.
All right. So osteoporosis is a very tough topic from a point of view of understanding the physiology and the endocrinology. So there's not going to be a typical talk that we would have done historically at a Tuesday afternoon at the Journal Club at WITS. The request was to just have an approach to managing osteoporosis and to keep it basic. And of course, for those of you who've come first time, our audience has dietitians, nutritionists, general practitioners, a few endos, a few physicians, lots of homeopaths, a few people from functional medicine. So I've got to basically try and cater to that wider audience. So we're going to try and keep it basic but practical because none of us are going to actually have an exam on this. So it's going to be an approach to osteoporosis, and we'll touch a bit on physiology. We'll look at how we're going to be screening patients, and then how we're going to be managing the patients. So these are my disclosures. So let's start. So osteoporosis. So let me just tell you that basically the guy who taught me endocrinology, Prof. Shires, his favorite topic on this planet is osteoporosis. And he used to really get excited about bone. And we were also fortunate enough to have our osteoporosis clinic at WITS for a long time that was run by Prof. Lipschitz started it and then was taken over by Sue Brown, and it carried on for many years. So osteoporosis is a systemic condition. It's characterized by weakening and deterioration of the skeletal system, and that includes spine. So having osteoporosis makes the bones more fragile and more susceptible to fractures, which can then cause compression fractures at the vertebrae, which is in the spine. However, this extends to other joints as well. So this picture just shows you what can happen at the level of the spine, but what's common are hip fractures. You can have forearm fractures, but basically you can have fractures elsewhere as well. So why does this become an issue? So there's lots of data put out there, and it may vary from country to country. But the long and short of it is women are more at risk of developing osteoporosis than men, but it's not only unique to women. Men have about a 15-year gap before we catch up on the same curves that females do. Now, 1 in 5 women are going to be affected by osteoporosis. 1 in 20 men are going to be affected. So this is just looking at American data. We don't have hard, fast data in the South African population, but over 43 million Americans over the age of 50 have a low bone mass. And then bone loss, we must accept that is part of the natural process of aging. So like we have aging of the vascular system, which can manifest as hypertension, aging of the neurological system that can present as dementia or Alzheimer's, osteoporosis is aging to the bone. Now, an important fact that you may or may not know is that if a female has a fractured hip, they have a 25% chance of dying within the next few months. Another 25% will never go back to their former selves. And about 50% will eventually, after a period of 6 months to a year, recover. So that's staggering data. And males are no different. So although whilst it's rarer in men, once a guy gets a hip fracture, chances are 40 to 50% of them will end up not being around 6 months after that fracture. So that's an important thing for all of us to know, that we mustn't take it lightly. So how do we try and prevent bone loss? Well, it's difficult to prevent bone loss, but what we can work towards is achieving an excellent peak bone mass. Now that's important because peak bone mass is something that develops in the first 2 decades of our lives. I'm just trying to get the laser. Here we go. So from the time we're born, as we grow, we get various stimuli coming into the bones, to the bones, and basically we then form bone. But we also mineralize it, so we're looking at quality. And so what happens is, at about 21, we all reach our peak bone mass in terms of the advantages we have with some of the hormones, the sex steroids, growth hormones being in the system for from birth. And so what happens is, this is an important concept to understand. So if I reach my peak bone mass over here and somebody else gets it over there, and another gets it over there, what happens is, that's the trajectory we're going to be on. And as we get older, after 30, we're losing bone mass. And so what happens is, if you follow this trajectory, the higher you start off at, although you're going to be losing bone at more or less the same rate as somebody a bit lower than you, the point is you're going to get to bone threshold where fracture happens much later. And so that's why this peak bone mass is very important to try and achieve. And we're going to talk about what influences that. None of us can escape this trajectory. And so this one is where females end up losing a bit more to males because of loss of estrogen. So that's peak bone mass. Now, I'm not going to go and talk about the risk factors that are not modifiable. It's an academic thing, and in your practices, it doesn't serve you in any better way. So if you're genetically predisposed, for example, if there's a family history of osteoporosis, you're not going to be able to change that. If you're female, you're not going to be able to change that. And so from that perspective, I'm going to rather concentrate on the risk factors that are modifiable. And so exercise, we'll touch on that, supplementation. But what's important is that if your client is a smoker, they should definitely consider stopping smoking. And smoking comes into many medical conditions, but especially bone. And surprisingly, males that are smokers will tend to lose more bone than females. Alcohol consumption, so we need to keep it 2 or less, above 3, and it definitely influences bone loss. And then bone density is definitely influenced by body weight. So we see this in the extreme setting where some females or males are anorexic. So BMIs below 20 will definitely have issues with regards to bones. And then we're going to touch on medications. But for those of you who are not doctors, maybe make some recommendations, but don't change any medications until you've managed to speak to the doctor that started those treatments. For example, if somebody's on an anti-epileptic, yes, it can affect bone, but you obviously need to be careful about stopping those. And then there's some work showing how excessive intake of caffeine can influence this as well. Let's touch on the pathogenesis. So this is a nice example showing you this is bone, and on the surface of bone, you get cells. Two big ones that you need to know: the osteoclasts and the osteoblasts. The osteoclasts will basically reabsorb bone. So I know when I was young, you just thought bone was an adynamic organ, but it's a very, very dynamic bone organ, but it's very slow in terms of its turnover. And so bone turnover can take up to 18 months. And so from that perspective, what happens is there's active reabsorption of bone taking place all the time. And so what these osteoclasts do is they release enzymes that then break down bone. And then, of course, at the same time, we have osteoblasts, which then appear on the site where reabsorption took place, and then slowly are basically going to be laying osteoid and then reform bone. So from that perspective, the balance between how much is lost and how much is gained is very important, but it also tells you that it is influenceable. So for somebody, let's say, who was sedentary, no weight-bearing exercises, poor nutrient intake, and if their bones are weak, you can influence it just by lifestyle changes. Whether it's going to be enough or not needs to be seen, and then some treatment changes need to be brought into place. So what's important is then the rate of reabsorption. If it's higher than formation, then you're sitting with the risk of osteoporosis, first osteopenia and then osteoporosis. So bones become weaker and brittle. The bone mineral density is decreased due to the deficiency of calcium and vitamin D. So what's important from a bone perspective, and we touched it when we gave the talk on vitamin D, I think about a month or two ago, is one needs to understand that once your client is deficient in calcium, for whatever reason, and there's a few reasons for that, and we'll touch on that later, it's going to stimulate the parathyroid gland. Now, the parathyroid gland is sitting embedded in the thyroid gland, and there's 4 of them, and basically their job is to produce PTH. Parathyroid hormone's job is to reabsorb calcium from the bone so that the body gets its day-to-day requirement in terms of calcium. And so, again, this is a very dynamic process. So vitamin D deficiency can influence the absorption of calcium at many levels, and we touched on that when we spoke about vitamin D, and it's going to do it through a pathway of increasing PTH. So normally we do case studies towards the end, and this talk doesn't lend itself to many case studies, but recently I had somebody who was actually with me in boarding school come to me, and this was the issue. So the complaints were actually very non-specific. They were more related to fatigue, and the wife, who's been my client for a long time, thought it's best that this guy comes for a checkup. And what we found was the vitamin D was very low as part of the workup. So once I got that, in the next set of blood tests, I thought, no, there wasn't a need to do a routine calcium on this patient. And then when I did the calcium with the PTH, of course, the client got a shock. So what we see in here is that although we improved the vitamin D levels over that period of time, using 3,000 units of vitamin D3 on a daily basis, what we found is that the client had hyperparathyroidism. So the PTH was high, which then causes the calcium to be leached out of the bone and come into the blood, into the serum. And that hypercalcemia then becomes problematic. So most of the time, these patients would complain of constipation, polyuria, reflux. If it's left, they end up with premature cataracts. It can cause cardiac arrhythmias. It can cause basically fractures, kidney stones, because of the excess loss of calcium in the urine. So, I mean, if any of you come across this, this obviously has to be passed on to your local physician, or if there's an endocrinologist in town, because this basically needs surgical intervention and managed. So this guy's bones would then end up looking like this, as opposed to what a normal healthy bone would look like. So nature in its wisdom made sure that, I mean, imagine if the bones had to be completely solid. We would lose a bit of flexibility. We'd be way too heavy to be agile and escaping from the wild, because that's what it was all about, survival and procreation. And so from that perspective, when you look at the bone architecture, this pattern, this lattice work, is basically exactly what you see humans have copied with, like the Eiffel Tower. So it's made strong, and that's because the weight or the forces are distributed along these lines. Now, what happens is when the bone starts thinning and being reabsorbed, this is what it looks like. So that's what we talk about when we said the bone mass deteriorates or decreases. And that's osteoporosis. So clinical features, unlike many conditions, you know, like thyroid's got 36 different symptoms or signs, hypertension's got some. This one's a tough one. By the time you pick up features, it's a bit too late. Generally speaking, if it's been missed, it's going to be presenting as a fracture or as bone pain. And so the pain can be along the spine because of volume loss or microfractures. And if these are not intervened early, you can have kyphosis. You can have loss of vertebral height. So I'm sure all of you know that as we get older, we all end up being a bit shorter for two reasons. One is in terms of what's happening to the vertebral discs and their hydration levels. And so you'll always be a bit taller in the morning than in the evening. And then, of course, you'll be losing bone volume loss in the vertebrae, and that's going to cause a decrease in height as well. And I'll show you an X-ray a bit later as well. Early fatigue, like the client that came to see me. I'm going to show you a picture of the creases that you see around the abdomen. And this is very, very late once you start having fractures. Now, it's not just any fractures, it's having a fracture with low impact. So basically, with whatever happened, we were not expecting to fracture, and the client fractured. So what happens is you can see you start losing some height, but also look at what happens to this curvature. And because of this curvature, you end up getting these abdominal creases. This is still an old-fashioned sign that we were all taught when we were at medical school. So there's a negative sign. Your client, you get behind the client, you basically put your fingers over there and see and look at the gap between the last rib and the upper iliac crest bone. And once you're sitting with 2 centimeters, I mean 2 fingers or less, then we know we're sitting with a positive test, and the patient probably has vertebral fractures. So if you're going to manage this condition, we need to know who's at risk. So females are at a higher risk than men. As we all get older, we at risk. One of the commonest causes I see in the practice is gonadal deficiency. So all women will progress to menopause. And remember, estrogen is an anabolic drug, both in males and females. And so once you lose that, the trajectory of the bone loss is going to be faster. We mustn't forget that this happens to males as well. And it's not so much because you're losing testosterone, and what we used to think that testosterone, because it's a male hormone, is more anabolic. No, because remember, testosterone converts to estrogen as well. And we tend to have our estrogen, our testosterones a bit longer than women. They go into menopause a bit earlier, and we will actually start converting some of our testosterone to estrogen because of aromatase activity, which I think we're giving a talk in the next month or two on testosterone, and I'll cover aromatase activity there. But because we've got extra estrogen, that's going to come, but a bit later. And then certain race groups are at higher risk of osteoporosis, so Caucasians and Asians. We spoke earlier about people with low BMI. Family history of osteoporosis. You have to try and elicit that from your history. That's very important, because even if every other factor is good, family history is a very strong marker. Low calcium intake, especially in the formative years, when you're trying to build peak bone mass, that is definitely a risk factor. Smoking, excessive alcohol intake, we spoke about that. Low level of physical activity. So this is important, because in your youth, if you haven't done bone strengthening activity, you're definitely going to be having weaker bones or lower peak bone mass. Let's put it that way. Steroid use over a long period of time. Let's say your client was poorly controlled asthmatic or had juvenile rheumatoid arthritis or any one of those excuse me, conditions that require glucocorticoid use. And then, of course, prior history of fracture, because once you fracture this, it's already an indication that there is a weakness in the system, so that becomes a risk factor. So who do we recommend besides the group I've just mentioned in terms of osteoporosis? So every female above the age of 65 has to be screened. Every male above 70. So in other words, eventually all of us would have a bone density scan or one of the other tools. Now, over and above that, women above the ages of 50 who have the risk factors I've just mentioned, and then in men, the same story, about 50 with risk factors. There's another tool that you can employ in your practice, and this is by the Sheffield group. And you can download it, and you can see it takes into account your age, your gender, weight and height, history of previous fractures, family history of it, smoking, glucocorticoids, rheumatoid arthritis, any secondary causes of osteoporosis, which we're going to touch on, alcohol consumptions beyond 3 units, and then the score that you're going to be getting from your bone density. And it tells you what your client's 10-year risk or probability of fracturing would be. So how do we make the diagnosis of osteoporosis? So the physical examination, I told you, once we see that sign, it's late already. And I showed you that in an earlier picture. But then there are some tools that can be used. So one can use a DEXA report. Typically, some gynaes, some rheumatologists, especially radiologists, offer these services, and the medical aids do pay for them in the right setting. One can also use ultrasound. It's never been very popular in South Africa. You can use quantitative CT scans. This is important when you're looking at quality as well. And then there are other radiograph. I'm going to show you how you can use an X-ray, albeit a late sign, but you can pick up signs of osteoporosis there as well. So we do a bone density scan, and what do we get? We get numbers. So the only number you need to remember is that anything above -1 going in the positive direction means the bones are normal. And what is normal? Normal is measured against that we see in a 30-year-old, the average 30-year-old person. Low bone density, the medical term is osteopenia, is between -1 and up to minus or just under -2.5. So that would be the person who is going to be at risk of progressing onto osteoporosis unless you intervene. And then any score above -2.5 means osteoporosis. And the higher the score, the worse off you are. And when you're looking at the scan report, you take your worst number. And so typically, you'd get those numbers that I mentioned earlier, and then hopefully you'll get an image like this of a hip, and that is the most critical point where one can fracture. So that's where they score it. And basically, the client's age is going to be put on the bottom, and you can see there's some trajectories set there. So no matter what happens as we get older, you can see those downward slopes are what's being expected. The machine's going to put a dot where your patient is in terms of age, and then where their bone mass density is. And then over the subsequent years, they will plot. So in this particular client, you can see they were deteriorating as expected, because you can see they're following the slope. And then at this point, there was intervention. So there was some improvement. And you can see over the years, there were 4 bone densities done. And in this client, it was over a period of about 10 years. But it will capture all of this data as well. Now, you can't just measure it at one spot. Then you get it at another spot as well. And this is the same patient looking at the same area, but the right hip, and you're getting the same data. And then you get a composite reading in terms of what's happening with the spine. This patient had already some scoliosis, but that's what we're looking at. And the colors denote where the trouble is. And so you can see -2.5. So anything in the red here means we're in the osteoporotic range, osteopenic range. Now, you can even use X-rays. So if you look at this, so you remember we were all in grade 1 at some point, and we used to have these rudimentary drawings where if we had to draw a house, we'll draw a little rectangle or a square, and then we'll put a little triangle on top, and then we were asked to shade it. So I call that the pencil in the box drawing. So can you see this here? Can you see this is like almost somebody's outlined it with a pencil and then did a light shade over it. Look at this one, like a light pencil drawing, and then you've shaded in it. Light pencil drawing, and you've shaded in it. You're not meant to get that pencil-like tracing. That's already a sign of osteomalacia. Now, how can you use this tool to see if this patient's got osteoporosis? When you have anterior wedging, can you see? Look at the distance between that point, and from that point to that point. And can you see it's lost here? So when you have either anterior wedging, and very rarely you can get posterior wedging as well, that is definitely a sign, and it's late sign already. One of the earlier signs is what we call I don't know if some of you guys know about the reborn Christian sign, where you see the shape of a codfish. So look here, if you really stretch your imagination, can you see that's like a fish? Look, this is a nice fish. Look, can you see that? So this is starting to look a bit like a fish. So that also tells you that this patient needs better mineralization. So that outline that you see, and you need a good one to compare to, and you'll see on a good one, you don't see this outline. Yeah. And the density of the bone would be a little bit more. So that and the reborn Christian sign definitely means we need better mineralization. That's osteomalacia. And then anterior wedging is definitely a sign of osteoporosis. So this is what it would look like if you actually have the skeleton out. Can you see that? So what are the treatments available? So here's a list. So nutritionally speaking, calcium and vitamin D are important. We can look at hormone replacement therapy. We're going to touch on that. We can look at the SERMs, the bisphosphonates, calcitonin. There are other newer biologicals. And then there are the non-pharmacological interventions which are important as well, like preventing falls, weight-bearing exercises, that kind of stuff. And then there are certain drugs on the market that are not punted for the treatment of osteoporosis, but do help bone, like statins or vitamin K, and then fluoride, which is what you find in your toothpaste. So it's very important to have a good protein intake from the onset. Vitamin D, the best source is the sun. The food's going to give you a lot of vitamin D2, and the sun's going to convert it to D3. Calcium intake, and we're going to go to the quantities. Your 5 vegetables of the day will be important for all the other nutrients. And then vitamin K2, we're going to touch on that as well. So there's always been lots of drama over the years and throughout my career in terms of how much bloody calcium does one need. So from that perspective, generally speaking, it depends on your age. So let's deal with women first. Osteoporosis is more common in them. So women under the age of 50 will need at least 1,000 milligrams of calcium and 600 units of vitamin D. This is in somebody who's already replete, remember, not through somebody who's deficient. So this is not for catch-up dosing. This is for somebody who's already good, and it's from a maintenance perspective. Once you're older, you need a bit more calcium and you need a bit more vitamin D. Ideally, the diets need to be good. In men, we got the same story. For under 50, above 50, up to 69, instead of 1,200, we need about 1,000, same amount of vitamin D. And then once men are above the age of 70, remember I said there's a lag of 15 to 20 years, our needs become the same because our risk of osteoporosis then is as high. So before we talk about how much calcium you're going to supplement, one mustn't forget that you're already getting calcium from your diet. So your worst calcium diet, I mean, unless you're extremely avoiding calcium, most people's general diet, even if they were not aiming to get a lot of calcium, generally speaking, you're going to be getting about 500 milligrams a day on your worst diet. So from that perspective, most of us only need another 500. It's important to know that the body can only absorb about 500, I think the exact number is about 540 milligrams of calcium at any one time. So you can take the best product that has 1,000, your body is going to pass the other 500 out with your stool. So it's not going to get absorbed. So from that perspective, most supplements should only have 500 at a time. Otherwise, the body is not going to really absorb it. And then you're going to have to take it in divided doses, which in most cases is going to affect compliance because they need many other things as well. So this is just an example of during breakfast, during lunch, during dinner, you're getting calcium from different sources. And basically, at the end of the day, most of us are getting 500. So This is a slide Leonie borrowed from my talk on vitamin D recently, and we said that vitamin D is very important for many organs, but the journey for vitamin D first made its way into science because of bone. And then later we find that it's got immunomodulatory properties. It's important for metabolic conditions. It's important in terms of cancers and a whole lot of things. But we touched on all of that. But primarily, it was bone. That's why all your reference ranges quote how much vitamin D is needed from a bone perspective. So if you just take a Lancet report and you look at vitamin D, on the bottom it will tell you that they got the target for treatment from the NOF guidelines. NOFs are guidelines, national, so it's basically our Osteoporosis Foundation of South Africa. So that was always a bone-centric reference range, because in the past, when we thought vitamin D was only important for bone, then they came up with a reference range to say sufficient and insufficient, because that terminology has been never used anywhere else for any reference range in all of medicine. You either get told it's low, it's fine, or it's too high. Nowhere have we ever spoken about the term sufficient. So it came because, was it sufficient for bone or was it insufficient? Now we think that a vitamin D of 20 is fine for all the other conditions. Yet the reference range speaks to 30 to 100, right? And nowhere else we're aiming for the bottom of the curve. And so here, we're not aiming for the bottom of the curve. The bottom of the curve, that's all you needed for bone. However, vitamin D is important for a lot of other conditions, so generally I aim higher. So we spoke about this before. I mean, you know, it's very difficult to get high doses of vitamin D3 now because of the debacle during COVID, where everybody was giving their patients and a certain company had their 5,000 units of vitamin D sitting on the shelves and giving it, people were using it without a script. So now SAPCRA's withdrawn high doses. And so that's why we took out the 10,000 of the whole again range. So we've got the 3,000 units, which is more or less a good one for most people. And like I told you, I aim for levels of around 50, and it can be taken any time of the day, and it's a nice, small, easy to take tablet. But then we've also introduced drops, because remember, any item above 3,000 needs a script, but one drop equals 1,000, so this can be gotten without a script. And then one can dose titrate for a child, for an adolescent, for a female client, for your male client, for your elderly client, for your pregnant client, accordingly. And this is the only vitamin D on the market that is mixed in MCT oil. So that means you can take it on an empty stomach, right? Because it's already got the fat it needs for absorption. But the rest of the products all got CEF oil, which incidentally, if you don't know, is inflammatory. It's the inflammatory omega-6. And people say, well, but it's just a little bit. Well, if you look and you realize that you're going to need vitamin D supplementation forever, because nobody sits in the sun for 40 minutes exposing at least 40% of their body every day, then over a 10-year period, you could get up to 3 liters. And so that then works out to a lot of CEF oil. In terms of an overall bone supplement, so remember, every clinical trial on every drug, which we're going to cover now, has always been on the assumption that the client was calcium and vitamin D replete. So the levels had to be good. Then they entered the trial, and then 5 years later, they reported on bone densities and whether their product worked or not. So this particular product has calcium in the glycinate form, which is the most absorbable form. It's 500 milligrams, with magnesium in the glycinate form, 800 milligrams. Now, I know some of you are going to say, but you need 1,000 most of the time. Yeah, but then you're not going to be able to fit it into one tablet because magnesium's fluffy and needs a lot of space. It's got 1,000 units of vitamin D, and more importantly, it's got vitamin K2. So K2 has become a big buzzword, and people are even combining K with their vitamin D. K just needs to be coming along with calcium because calcium does not have a brain. So when you give calcium supplementation, it has a choice to go wherever it wants to in the body, whether it's going to go to the bone or calcify the artery. That depends on what's happening with the physiology and the low-grade inflammation. However, when calcium is taken with vitamin K2, it forms a complex whose receptor is only in the bone. And so that way you keep it in the bone. So it's very well priced. It's got everything in one tablet a day. And it has to, of course, be big because it's once a day and it's got everything. Magnesium is important. So if you wanted a higher dose, it's in the glycinate form, 1,000, and it's slow release. So there's only 2 slow release products on the market. The other one, only the small tablet is slow release and delivers 43 milligrams. The effervescent and the capsules are not slow release. So like many other metabolic conditions, it is vitally important for us to encourage that our patients do weight-bearing exercises. Because I told you earlier that there's constant breaking down of bone, constant reforming of bone. So it's a very dynamic process. So the more strain you put on the bone, it will remodel and strengthen according to the pressures it's been feeling. And by here, it's positive pressure from weight-bearing exercises. So what are some of the treatments? So we've covered the nutrients, which are important. What about medical treatment? So once you've established that the client is osteoporotic or osteopenia and had a fracture already, then we either give the anti-resorptives, as the name mentions. So what it's doing is it's preventing the osteoclasts from reabsorbing the bone. So that means you don't lose bone. For those of you who are saying, oh, but that's a problem, you're right. Because if you're not reabsorbing bone, that means you're not going to be able to remodel as well, isn't it? And so ideally, we'd like a dual process. But this is what first came on the market. And you got the bis class of drugs called the bisphosphonates. And you had different generations of bisphosphonates. So at the moment, we've got the alendronates on the market. These are the ones that can be taken on a daily basis or on a weekly basis. I'm going to give you an example, like Fosamax. Then you get the residronate, like the Actonel. This can be taken daily or weekly or monthly. The abendronate is available orally and intravenously overseas. This is a 3-monthly injection, but we've got the oral treatment, the Boniva, and this can be taken on a monthly basis. So from the time when I qualified and you had to take a tablet every day, you can see its progress to becoming a lot more patient-friendly. And why did they have to do that? Because this is not one of those easy drugs to take. So first of all, it has to be taken in the morning. It needs to be taken on an empty stomach. It needs to be taken with water, cold water in particular, not sparkling. One needs to take it. And then for this one, you're not allowed to eat for half an hour. For those, you're not allowed to eat for an hour. And you need to be erect or sitting for that time period. Because if you lean forward or you pick something up from the floor, it has a very bad side effect of reflux. So from that perspective, can you imagine that you have to take a drug every day, sit bloody erect or walk around for an hour, take it with cold water, even in winter, and not eat anything for an hour. That's why the compliance was so shit. So they had to develop something better. These are expensive, but the costs have come down since the generics have come on the market, and the medical aids do pay for them, preferentially over the other more expensive options. Then you've got the IV bisphosphonate, which can be given as an annual infusion. And it can be given from anything over a 15-minute period to 2 hours. And it's very convenient. And all of these need to be used for a period of about 5 years. The advantage of the bisphosphonates is that once you use them for 5 years, you basically take a break from it, but it still has residual benefits because it worked on the osteoclast, and that residual effect, because these things accumulate, that's why they call bone poisons, they accumulate in the osteoclast. So that means it's still going to be effective for a while, and then the good doctor is going to be doing bone densities. You treat it for 5 years, and then you wait a year, and then you do the bone density again, see if it's deteriorating and whether you need to come in with a different class of drugs or not. The drips do have a side effect where some patients will complain of a flu-like illness. So remember, you're going to be giving it every year. So if that's happened in previously, I just normally tell our patients take 2 Panados or take an aspirin before you're going to come in for your infusion, and then you sort it. Because if you do get a flu-like illness, it's normally there for the first 2 to 4 hours. Part of the injection, one of the side effects is bone pain because you have rapid remineralization in some patients, or like a mini hungry bone syndrome. So you can get pain, but it normally resolves. Then you get the SERMs, the raloxifenes. SERMs are selective selective estrogen receptor modulators. They fool the body into thinking that that molecule is estrogen. It sits and activates the receptor and then activates it going forward. And so, but these cannot be used in premenopausal females, only in postmenopausal female. Hormone replacement in females, so it's not classed as a treatment option for osteoporosis. However, it will serve to improve the bone, or rather decrease bone loss in the event that you've got a female patient who requires HRT. You've gone through all the pros and cons. You've decided to use transdermal or tablet, and then so you replace the estrogen, and there it's going to act to help in terms of decreasing bone resorption as well. And so in the younger female who had premature ovarian failure, or for whatever reason ovaries removed, or had breast cancer at an early point in their lives, and for them this form of replacement is fine. The one with breast cancer, they tend to use tamoxifen, which can act as a SERMs, but estrogen, and we're coming to that topic, I think next month or the following month, we're going to be looking at premenopausal, perimenopausal, and postmenopausal, and then I'll cover how you and what type of estrogens you're going to be giving there as well. So that also helps decrease bone loss. And then we no longer use calcitonin. This used to be a subcutaneous injectable or intranasal form of treatment. And it was just making its way out when I actually qualified as an endocrinologist. But since then, there's many easier forms of taking it. So these are the anti-resorptives. And if you're not comfortable using them, that's fine. Just refer your patient on, and there'll be a physician or an endo that's managing bone in and around your area. Then you get the anabolics. So here, the anabolic is not anabolic like steroids that men use in gym to build their muscles. This is anabolic from a bone perspective in terms of building new bone. So PTH is a hormonal replacement, and PTH is given as an injection. It's called Forteo. It's expensive. And initially, it used to be reserved for people that used one of these and still fractured, or people with a score above 3.5, and they had to go through somebody that's been a member of NOFSA, and the medical aid would then pay for it. So it's still expensive, it works, and it's an anabolic drug. That means it's not only preventing further loss, but it's helping you build bone. And then this particular product we don't have in South Africa. Shit, you know what? I actually took out one here because I first had it at a list here. So that's the biologicals. So these are biological. Basically, it blocks a protein that activates the osteoclast cells that will break down bone, and that's denosumab. So denosumab is an anabolic and an anti-resorptive, so it fits in on both categories. And that is an injectable that can be used every 6 months. It's shockingly expensive. Prices are coming down, but again, it's reserved for failure of the other treatments, or these, once you've used this for 5 years and then you're starting to lose bone, then you're going to have to move on to this, or you've been on this, then you have to come off it for a while, and then you have to use another agent. That's when those agents come in. Again, those are reserved for geriatricians and for certain physicians or endocrinologists. So that's from a treatment perspective, your approach. This is Naughty Leonie. She's putting her product here for alcohol, because remember we said anybody who's consuming more than 2 units, above 3, you're at risk. So Liver Balance has NAC, which is direct precursor to glutathione, which helps the liver because it's an antioxidant as well. But this product has vitamin E, the legal amount allowed in South Africa. So I know people say, but it's supposed to have 800. You're not allowed more than 400. Otherwise, it needs to be registered as a medical product. It's got milk thistle, it's got dandelion extract, and it's got kudzu as well in terms of helping the liver. Estrogen balance, we're going to cover that in a few weeks' time. That acts as a natural SERMs, by the way, because the sulfurans there act as selective estrogen receptor modulators. So that's why she's put that there. So here I'm going to end with a client of mine who I've been following up for years and years and years. And this is, I think I've known this patient for close on to 23 years from the time I started the practice in Melrose Arch. And at the time, I mean, she was definitely on the very thin side, very fragile, and was already sent to me with a level that showed that she had osteoporosis. So if you look, it was already in the pink zone. And then over the years, it improved. And then she went through a divorce, and the husband refused to pay for any treatment. And then it deteriorated. And then we slowly started recovering. So remember, you will never get a nice trajectory going up that way. Although these results look mediocre, this is actually good that you're maintaining bone that has been lost already. She incidentally chose the injectables in the beginning, and then from this point onwards, she hasn't been on any bisphosphonates, SERMs. We just always continued with her HRT, transdermal HRT, and she's been on a good regimen to keep her calcium levels replete and vitamin D. Now, I forgot a very important thing. Sorry. Calcium. So the type of calcium you use does matter. So calcium needs an acidic medium to improve its absorption. So that's why calcium carbonate had to be taken on an empty stomach when there was acid. calcium carbonate is the worst. When I use the word worst, it doesn't mean it's bad. It's not useless, but it's the worst from all the calcium supplementation from an absorption perspective. The next best would be calcium citrate. So why did they come up with citrate? They came up with citrate because you didn't have to take it on an empty stomach, because it already comes in an acidic form. And then you get calcium glycinate, which is the most absorbable form. So you don't have to worry when you're taking it. And because it's bound to an amino acid, the body will always grab protein. And so any amino acid, it absorbs and thereby getting its calcium as well. So this is now the other hip. I'm not going to painstakingly go through this one as well, but look at her spine. Now, although this might not look amazing, you can see from there onwards, we've had a nice improvement over the years. And this is with her not taking bisphosphonate. Now, this is somebody who does yoga every day. This is somebody who's exceptionally healthy. I mean, my friends always say, what the hell, you're going to live forever, and when you die, somebody's going to get your organs and bust it in 6 months. So this is that kind of a patient where in terms of all her other bloods, she's doing very well. So I'm going to end with these two little posters, and you can try and get these posters, maybe put it up in your practice. It's a very easy, quick thing for your clients to see. So, now you can see I'm messing things up here, but. So here on the top, we talk of symptoms, and I told you there isn't much. Back pain, if you're sitting with microfractures, you will lose height, and this is a goddamn late sign. And then in terms of risk factors, we covered it. It's females, it's men, especially who are smokers, alcohol, more than 3 units, smoking, family history is important, sedentary lifestyle, not enough sunshine, people with a low BMI, low testosterone in men, certain medications, especially steroids. Those are the big guns. Your azathioprines, I think the next page covers that one. I'm going to go through it in a little bit. And then in terms of diagnosis, you can use a DEXA scan. We don't have much use of ultrasounds in South Africa. And then this is more for endos, where we look at bone turnover markers. And then we covered treatment. It's not only medication. It's important if females are there, and if the situation is right, give them some estrogen as well. The nutrition for bone is important. And then exercise becomes important. And then prevention is important, because by the time your patient's had a fracture, listen, the bus has left the station already. So you want to be preventing. Now, one of the key things we tend to forget when we're managing our clients who are at risk, make sure they don't fall. If they don't fall, they don't fracture. So you basically need to start working on the core, and that's important. So I used to be an avid yoga practitioner. I don't teach it, but I used to do it. And then I took up karate. And for a long time, I was doing karate, and I've been active and I exercise and everything. And for those of you, maybe I mentioned it in one of my other talks, I went and ruptured one of my, the L5S1 discs. So for the last year, I couldn't do much. Now, in order to accommodate for that pain, you end up doing things you're not meant to. And then I could do, there's something called Trikhosana. It's a posture in yoga where you lift your leg, one leg up, and like a flamingo, and you put it in position, and then you lift your arms up and you do like a namaste sign, and you do that. And I could hold it for so long without ever falling. And it was laughable because 6 months ago, I tried it and I couldn't do it. And I couldn't do it on both sides. And it's amazing how quickly your body can lose your small core muscles. And it took literally just 2 or 3 weeks of doing that daily, and it's come right again. So don't underestimate the importance of building core muscle, because it will decrease your patient's risk of falling. And then make sure that you tell your client about getting aids so they don't fall. If they got stairs, make sure they've got a railing. If they're in a shower, make sure they got a bar to hold on to. They mustn't be walking on uneven pavements. But South Africa is full of potholes. So, you got to watch these things, because if you fall, you're at risk. Vitamin D is the only supplementation that's been shown to decrease fall risk and improve balance. And then, yeah, this is the one I was wanting. So I want to end off with this. So in terms of what we should be looking out for, patients that have taken steroids, people that have taken PPIs, because you're decreasing your calcium absorption, anti-epileptics, anticoagulants, these are all putting clients at risk of osteoporosis. There's renal conditions. So once you've got chronic renal failure, as the GFR is dropping, what happens is the phosphate starts climbing because you're not clearing the phosphate. The calcium starts dropping. The vitamin D, remember, kidney is one of those organs that are important for the conversion of making active vitamin D. That starts dropping. So what happens is you start stimulating PTH, and PTH causes calciuria. You peen out the calcium. The calcium is going lower and you're losing bone. You can get adynamic bone disease with kidney disease, and you can even get adynamic bone disease when using bisphosphonates for too long. What is adynamic bone? You're not building new bone. So remember the bisphosphonates, you're breaking down osteoclasts, you're preventing it from reabsorption, but you're also not allowing osteoblasts to put new bone. It's going to sound complicated for those who haven't studied this, but do you know where you get osteoblasts from? From osteoclasts. So if you're inhibiting osteoclast activity with the bisphosphonates, you're not allowing the osteoblasts to form, so you're not getting new bone. So sometimes if you use it for too long, you can get adynamic bone. That's why you want to stop, allow the bone to mineralize and strengthen. Then you can get osteomalacia, and then you can get mixed renal osteodystrophy. From an endocrinopathy perspective, people who are diabetic are at risk. Hypogonadism, at risk. Patients with an overactive thyroid or underactive but overtreated, where the T4 levels are too high or T3 levels are too high, you can get increased bone turnover and osteoporosis. Parathyroid adenomas, I gave you that example earlier. We spoke about smoking and genetics, certain infections, certain oncology conditions, chronic inflammatory autoimmune conditions, malabsorptions. Those are obvious because there's low-grade inflammation, but also you're not absorbing nutrients too well. And then, of course, bad dietary habits, starvation, anorexia, excessive oil, alcohol, all of this can lead to osteoporosis. So these are Leonie's details for the ones who want to stock, for those who want to communicate with her in terms of questions. Sometimes, I told you guys, don't refer patients unless they're really tough to manage. I'm happy to take WhatsApps, or better still, work through Leonie, email your queries, and then I normally jot down a suggestion or an answer. Always willing to help, because there's very few of us and all of us are too busy. So it's always good if you guys can manage these patients. So this is her details, and let's stop there for questions. So I did say This was going to be one of our shortest talks. And let's see if I can get you guys to the question. Recording. So any questions? Any questions, guys? I'm just trying to find the picture where I can find you guys. There we go. Share it. Sorry, guys, I'm not seeing the questions. Ah, here we go. Okay, there's 56 of you now. There were 57. So there must be questions. Let's see. Here we go. Elevated homocysteine and risk for osteoporosis. So always good question. So homocysteine, we normally associate it with more from a cardiovascular risk perspective in terms of stroke, but of course cardiac as well. And then high homocysteine levels, important because there's a higher risk of Alzheimer's, Parkinson's, autoimmune. In the field of medicine, we only know high homocysteine as homocystinuria, where it's extremely high. But remember, the Framingham study showed that if your level is 6.1 as opposed to below 6, you 2 times more likely to get a stroke. If your homocysteine levels are 9.6 or more, you 3 times more likely. And if your levels are above 12.4, then you're 4 times more likely. So that was considered an acceptable risk. That's how come on the reference ranges, they quote up to 12 as being normal. So for most of my clients, I aim for level below 4. And yes, when it's extremely high levels, I would say there would be a risk. But that's not what the levels we see in the practice. This is exactly what I do in my practice, balance and proprioception. Fantastic. So somebody at the fitness hybrid basically helps client do this in terms of helping them with balance, that whole proprioception thing that I spoke to you about where I couldn't do my tricosana. And my mom's bone density went from 80% to 95 in 3 years from exercising and nutrition. So now there's only a 5% deficit. There we go. So that's like the patient of mine that I showed at the end. We mustn't underestimate the importance of weight bearing, obviously the correct exercises, because you're on a fracture in the process. Does iron influence calcium absorption? So iron and calcium compete for absorption. Calcium and iron both interfere with thyroxine absorption. So we mustn't forget that. And to that, I know this is not a thyroid talk, but PPIs are not only influencing calcium absorption for this condition, but PPIs also affect absorption of thyroid hormone. So here you need to be careful in terms of what you combine. I'm referring to the prenatal supplements that contain both one, yeah. And so that's why I always separate it. Mark Late, thank you, Dr. Bhana. Competitive inhibition with iron, yes. Can I email you chemo-induced? Yeah, so sure. Kelly, you can definitely email Leonie and we'll see what we can do for your chemo-induced osteoporosis. Thoughts on prescribing 50,000 units of vitamin D once a week for individuals with vitamin D levels of 15. So I can tell you, and I've done a talk on vitamin D, and we had real life cases. And I think the person who asked the first question, Uwais, actually, I used his case study that he had referred to us. So I get a lot of patients using calciferol, 50,000 units once a week. It's fine. And it's easy to use. The problem is when you look at the levels, they're normally mediocre. They're sitting between 15 and 25. Which might be enough from a bone-centric perspective, However, in our practices in functional medicine and for certain endocrinopathies and for immunomodulatory issues, you want that vitamin D at least 50 to 60. And I mean at least 50 to 60. There, I don't get joy with it. So I've got tons of patients and I've given you guys examples, real life Lancet reports, and I showed you we're just prescribing 3,000 units of vitamin D3 takes them between 35 to 50. Yes, there are some people who need more. That is why we used to have the 10,000 units. And now we've got the drops. So unless you're getting your patient to take calciferol and he's sitting in the sun for 40 minutes, exposing 40% of the body, I'm not getting good results. In fact, today I had a client who was taking 50,000 units every 2 weeks and had a level of 8. And she is not somebody who's covering herself. Thank you, Dr. Bhana. I'm no doctor, but exercise for sports for the 16 year. You talk about helping patient in my practice. I want to live disease-free lifespan. Yeah. And that's an important thing. In terms of, we're not all trying to live till 120. I don't think we have enough money to do that. I think what we're trying to do is increase our lifespan, make it more fun, make it healthy, run to the end and not crawl to the end. And that's why nutrition and physiology, I think, are pivotal. So I don't know, are there any other questions? No. So this was the shortest talk we had. Thank you. I do see a fellow endo in the audience, so I apologize. This was kept at that level. I mean, normally we would talk a lot about bone physiology, but this was mainly just to enhance most people's practices. So I hope that was helpful. And again, we welcome suggestions in terms of topics that you might find beneficial. We're going to be doing testosterone replacement and physiology and what to look out for. And then we're going to be looking at estrogen in premenopausal, postmenopausal, and I'll touch on the how to replace and monitor that as well. So sorry, one more question here. So what dosages would you recommend in juvenile osteoporosis? Listen, they might need lower doses to get to those targets. But for osteoporosis, you want all your clients to be at least 30. And if they've got other issues, you want it to be higher. Somebody said, I would love a talk on endometriosis and PCOS. Remember when we spoke about, and I think Leonie's got this thing online where you guys can go and listen or watch that recording. But when we spoke about estrogen dominance, where the estrogen levels are too high and progesterone levels are not sufficient, that sets the tone for endometriosis, fibroids, first trimester miscarriage, breast adenomas, higher risk of breast cancer, zits in the T-zone, pigmentation issues, melasma. So I see 4 people have put their hands up there. And then in terms of PCOS, that's a separate topic. So PCOS is based on insulin resistance, and you get the hyperandrogenism and cycle issues. I don't know if I've given a talk to this audience or was it Dr. Motada's audience, but we'll go back, and we haven't, we'll go through it again. And then if we have, and there's still a lot of you want a talk on it and not the recording, then I'll go ahead and I'll do it as an extra talk for that month. How do we increase progesterone in a controlled way? Aisha wants to know. Fasen? No. Okay, no. Fasen is, can we use Fasen in endometriosis? Yes, but we will talk about that. So controlled fashion is progesterone. So you can use transdermal progesterone creams, which can come in a 1, 2, and a 3%. You can use progesterone that is micronized, and made by the compounding pharmacy. So Fagron makes it in a 15, a 25, a 50, 100. And then in the pharmaceutical range, you got Utrogestin, which is a bioidentical micronized progesterone. It comes in 100 milligrams. So it's easy to replace it. If you're asking how do we increase progesterone, that's where that estrogen balance came in, the one Leonie slipped in the store, where estrogen balance is one of those sulfurans that has all three forms of sulfuran. So you've got something that comes from nasturtium, you've got something that comes from cat's claw, you've got something that comes from Brassica italica. So all of those sulfurans in the highest doses in the industry, trust me, turn that bottle around and read the data, is in one product with I3C, indole 3 carbinol, that decreases the conversion of estradiol to estrone. It's got DIM that does the same. It's also got calcium deglutarate to prevent the recirculation of estrogen from the gut microbiome back into the system. And so that product helps balance the estrogen and progesterone. Now, it's not for everybody, so you've got to try it and see if it's improved. In a small percentage of patients where it hasn't improved it, you can then add progesterone, or you can try Donquire, you can try this. This is where the homeopaths have a forte in terms of improving progesterone. So there are other products, mainly from a homeopathy perspective, but yeah, you can try and balance it. So I'll leave it there. Thanks, guys. Have a good evening, and we'll see you guys in the near future.